Alert Medic 1 respond. Box area 19
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Medic 1 podcast. It's Ken Sanner here, one of your hosts, along with my good friend.
Hey guys, it's Moose. Thank you.
Hey, and we have our special guest, Erin Berry. She's a nurse. She's a flight nurse, and she's going to tell us all about Ecmo. It's a great topic. It's something that a lot of us know a little bit about, but very few of us know a lot about. So I think we're going to jump right into it because it's a great topic.
So, let's get into it. So Ecmo, what's it stand for?
So ECMO is extracorporeal membrane oxygenation. And ECMO, if you can go back into the history, it was created at University of Michigan. ECMO used to be strictly a pediatric treatment. And then I don't know when it really bridged over to adults, but it's kind of bridged over into adult critical care. And it's really been amazing, specifically with all of the flu that's been going around, getting these young, healthy people with these horrible flus and pneumonias and getting them through that. And then also interestingly, the ECPR programs that are popping up everywhere, ECMO's played a huge role in that and getting people, it's increasing survival for things that you just weren't seeing people survive.
Could you go into, and maybe you're already going to be going into it, but like specifically ECPR stuff, because that blows my mind. Like how that even has an effect. Like that's amazing.
So with your ECPR, it's your patients that have gone into cardiac arrest, specifically the ones that are in like a refractory arrest, like can't get them out of VFib. But you know that there is a reversible cause. Like you had a witnessed arrest, you know that this person's got some type of MI, and you know if you can just kind of like get them through this, they're gonna come out. So you crash cannulate them on VA ECMO to give their heart time to recover. Like it gives you a chance for interventions. If you haven't already taken them to the cath lab, now you can take them to the cath lab. And then it just gives the heart the time, the rest that it needs to get better.
So you mentioned VA ECMO. I think that's a good transition into telling us the different types of ECMO, right?
Correct. There's two different types of ECMO, and you want to pick the right ECMO for what you need. So you've got VV ECMO, called veno-venous ECMO, and then you've got VA, which is veno-arterial ECMO. And with your veno-venous ECMO, what you're doing is replacing what the lungs are doing. With your veno-arterial, you're replacing not only what the lungs are doing, but you're also replacing what the heart is doing. So these patients in full-blown arrest, VA ECMO is going to give them what they need. But if you've got an ARDSI patient who's got the flu and pneumonias and their lungs just need some time, your VVD ECMO is going to be what's right for you. So you're going to have, so the ECMO itself does a couple different things. We'll start with just VV ECMO. Your VV ECMO is going to do both oxygenation and remove CO2. So you can be hypoxic and hypercarbic, and VV ECMO is going to fix both of those for you. And then your VA ECMO is going to be able to do both the hypoxia and the hypercarbia, but it's also going to be able to do circulatory support. And the oxygenation and the CO2 removal are accomplished through like a little oxygenator that flows oxygen and mixes it with the blood and basically does what the lungs aren't able to do. And then it's also got something called a sweet fluid that's coming through and pulling out that CO2. And then the VA is basically what it's adding is a pump that's providing circulatory support.
So how does the and I don't know where I have this mental image from, but I feel like I have, from what I remember, there's like this retrograde circulation. So like maybe it's VA ECMO or VV ECMO. I don't know.
So you can see recircing with VV ECMO patients that are peripherally cannulated. What you're talking about is, so you can be peripherally cannulated and you can be centrally cannulated. So a peripherally cannulated patient, typically you're going to go in your big vessels. So you're going to go in your IJ, you're going to go in your femoral. And if you say you're going to have two sites, you're going to have a site that pulls blood out and a site that pushes blood back in after it's been treated. So if let's say you've got a right femoral and a right IJ access, and those cannulas are too close to each other, the cannula that's returning your oxygenated blood, it can just be shooting that oxygenated blood straight into the cannula that's pulling out, and you're getting a phenomenon called recirculation. So that's been fixed is just being sucked and pushed back through the system and not delivered to the patient.
You're circulating blood, right? And anytime blood is being pushed through anything that's not, I feel like, organic, you have to worry about lysing, right? And mechanical damage.
You've got a couple of concerns. You've got lysing, which is a concern, especially with VA ECMO, because you're pumping. And then you've also have a concern of clotting. Yes. So it's twofold. The clotting is typically accomplished through heparin. So when these patients get initially cannulated, they get a big old bolus of heparin, and then they'll typically be put on a heparin drip. And then for the lysing, it's typically controlled through pump speed. So if you're seeing a lot of lysing, you try and back off the flow rate to see if you can get it going a little bit slower and still accomplish the goal that you're looking for.
How are you going to know if your patient's having lysing? What are they going to present with that you're going to be like, oh, we've got an issue going on right now?
So you'll see sometimes you'll see like a breakdown of the red blood cells in the urine. So the urine will change color. You'll see issues with like low levels. Lysing is typically less of a concern than clotting. Clotting is your big concern.
Okay.
Are you shooting for a target INR, or how does that work?
You're typically shooting for a target PTT, and it's been a while since I've been at the bedside, so I honestly don't remember what their goal is.
Okay. And I guess we could talk on a separate episode on like what INR and PTT is, I guess. But just, do you want to give a quick summary of?
So INR there is two different ways to measure your coagulation, and different medications impact different measurements. So let's say you've got a patient on Coumadin, you're going to be checking their INR because that's what's going to be impacted. And say you've got a patient on heparin, you're going to be checking their PTT value because that is the factor, like in the coagulation cascade, that's going to be impacted by heparin. And then you've got these weird ones where you've got like Xarelto that there's nothing you can test.
Mm-hmm. So there, when we are, what was I going to say? So you have these ECMO patients that you have essentially taken over their heart and their lung, right? Oftentimes these are patients that we're bridging, right, towards transplant.
Right. A lot of, there's definitely, you can bridge to heart transplant, you can bridge to VAD, you can bridge to lung transplant.
So, and that's doesn't that open up a potential for a huge like ethical dilemma? Like, say an organ doesn't present. I mean, which I know they do.
Yeah. But... So sometimes things are referred to like as a bridge to nowhere. So with the ECMO, a lot of ECMO is used as a bridge to lung transplant, and these patients can be on ECMO for very long periods of time. They actually have a special cannula where you just have one access site. It's called an Avalon catheter that they can use for these long-term ECMO, like VV ECMO patients that are just waiting for a lung. And yeah, there can be some ethical considerations with the long-term ECMO. I definitely know of patients that have been removed from the long-term life support because just nothing's coming available for.
Now they also have, so just like how you would have with like an LVAD, you have, pipes going into your body through openings in your skin. So that opens up risk for infection, right?
Yes.
So how are there like specific antibiotic regimens that are usually prescribed?
So it's more about line care for those patients. So the nurses that are taking care of these patients long-term in the ICUs, they are very, very regimented about how they take care of these lines and the types of dressings that they put on them, and how often they're changing those dressings. That's going to be like your front line from preventing infection, is like maintaining the cleanness with the dressings.
Okay. So, and I think doesn't happen a lot at all, but you're never going to be, I guess you're tracking temperature just like anything else, and inflammation at the site, and, purulent discharge at the site.
Mm-hmm. Yeah.
Because that,
temperature gets a little tricky with ECMO because you're pulling, it's if you've ever, and it's similar to the continuous dialysis that you do. Anytime you're pulling blood, like all of your blood, and exposing it to room temperature and putting it back in, you obviously have a heater, or you're controlling the temperature, but it's very easy to miss temperature changes because the way the equipment operates. Like you will often catch it because you're not having to warm the blood as much. So that's kind of a trigger, but they'll be checking like blood cultures and other things on these patients and white counts, and temperature is probably not going to be your first sign.
So, and I honestly have a ton of questions. So the next thing that I want to bring up is something that you opened my eyes to, Aaron, is who are the people that are managing these ECMO machines?
So ECMO machines, in the OR, they're always managed by something called a perfusionist. Once you get out into the ICUs, it can vary, but they all have special training. So they'll call it sitting pump, but there'll be either a perfusionist, or a lot of hospitals will train respiratory therapists to sit pump. And some hospitals will even train nurses to sit pump and kind of watch the flows, watch levels on gases, make adjustments to sweep, make adjustments to FiO2, make adjustments to flow rates. But it does require an amount of specialized training, and a lot of perfusionists are actually master's degrees.
That's what I found after you told me about like that thing exists, like the career exists. I looked into it, and there are a few bachelor's programs, but a lot of them are
they're extensively trained professionals,
and they make around how much like a PA would make, or like they make very good money.
It's good money.
Yeah. And so I spoke to one for the first time when I shadowed one of my physician friends who works at the LRU, and it is tremendous how much technical know-how along with physiological know-how you have to do that job.
Yeah, they're incredibly intelligent people.
Quite literally, you have the person's lungs or heart and lungs in your hands to manage.
Yeah, you can make or break that patient.
Yeah. So that's definitely interesting. So I want to go into procedure, how we actually cannulate these patients, and then let's open up the discussion to how the famous French pre-hospital picture of ECMO occurred. Like how do we get to that point?
So the cannulation process is, if you've ever seen someone put in a central line, you've got a little needle, you use your ultrasound and you poke it in the vessel, and you size it up, except this time you're going to really just keep sizing it up to they're essentially garden hoses. So you're gonna pick your sites depending on what you're trying to accomplish, VA or VB. Like I said before, the usual access points for a venous access is going to be your IJ. For venous or arterial, you can go femoral. I've even seen where well, I haven't personally seen it, but I've read where you can get axillary access as well, but I've never personally seen that. So it's going to be like any other line placement. You're going to prep your site, and then you're going to start ramping up, getting it bigger, till you get your garden hose in, and then clamp that one garden hose off, and then you're going to put in your second garden hose, and then, and mind you, there's chaos going around behind you because these are the sickest of the sickest patients. They're incredibly unstable. You're trying to keep their blood pressure up. You're trying to keep their oxygen levels as high as you can keep them. So it's kind of like a little circus going on behind them, and they're just putting these garden hoses in people. So you get your second garden hose in, and then you get them, you do what you call putting them on pump. And this is usually the most chaotic period, and then everything just calms down beautifully. But as you're ramping them up on pump, patients typically can get incredibly unstable. So you've always got like a slew of drugs at your bedside that you're ready to push. Specifically, you're going to be doing epi, you're going to be doing calcium chloride, and you're going to be doing bicarb to try and get them over the hump of getting used to being on the pump. And then the beautiful thing about ECMO is once you get them up and running, everything gets really easy. If the pump is running right and the cannulas are in the right place, these patients get so stable. Like you'll see, specifically the VA patients, you've got them on every pressor known to man, completely maxed out. You get them on pump, and now you have to put them on a nicardipine drip.
So how stay on ECMO safely?
So there are people that are on ECMO for upwards of a year or greater.
Wow.
Like your patients waiting for your transplant, specifically your lung transplants. But there's not really like a hard and fast end date. But I mean, you wouldn't want to stay on for a year, but there are people that are on for very long periods of time.
So
That's
who's typically in the room during one of these procedures?
So typically you'll have a cardiac surgeon that's placing the lines because they're fairly familiar with it from coronary bypass grafts when the patients are put on bypass. So you'll have a couple cardiac surgeons in the room putting in the lines, or depending on where you work, you would have maybe a trauma surgeon, because there are several trauma surgeons over at University of Maryland that will cannulate for ECMO, or even some ED physicians are being trained on how to do ECMO cannulation specifically for like the ECPR. So you'll have your doctors in the room. You'll have a couple nurses because they're going to be managing your drips. They're going to be pushing drugs, keeping the patient as comfortable as possible. You're going to have an RT in the room if they're vented, because believe it or not, you will cannulate for VA ECMO sometimes with a non-vented patient. I've done it before.
Oh yeah, that was the one that I saw, and the guy was awake like before, and then that was actually one of my next questions, like what agents are usually used if they are awake to sedate them, because well, no comment, I'm not going to say anything about that particular case, but yeah, it was just
so you're going to have nurses, you're going to have RTs, you're going to have physicians. If you've got techs on your unit, that's awesome, because then you've got someone running for stuff for you. But I would say, I mean, bare minimum I've had in a room is 3 people, and that's a bad day. But if 1 doctor and 2 nurses, but typically you'll have a couple physicians and a couple nurses, and you'll have your perfusionist there.
I want to talk about the drugs that you use. So you mentioned epi, you mentioned calcium, and you mentioned bicarb. So epinephrine, obviously, self-explanatory why we're using it, right? Calcium, is the goal to promote cardiac contractility, or
yes, that's exactly what it is. It's cardiac contractility.
Okay, and then bicarb is for generalized acidosis reversal, or
yes,
okay,
yeah, generalized acidosis.
So in terms of sedation, and this kind of goes back to so if you guys didn't listen to our TBI episodes, definitely go listen to them. You're probably looking for sedatives that are neutral to your your vital signs, right? So if you have
Right.
realistically, these patients are going to be hypotensive, right, because they're not
Mm-hmm.
circulating. What are some sedative agents that you all have used or you've seen used in the past? Because I think you'd want to shy away from, say, a Versed or or a benzodiazepine, and you'd probably lean towards maybe like an etomidate or ketamine, or how would that work?
Yeah. So it kind of it's obviously patient dependent. The one we did you so oftentimes with a VA ECMO cannulation, it can be for a pulmonary embolism, like a massive pulmonary embolism. And these patients are incredibly sick, incredibly labile. So you're cannulating them, and sometimes the only thing you're doing is lidocaine at the insertion site and a lot of hand holding. And then other times, a little bit of fentanyl can be helpful. We've definitely used ketamine. And then on your VV patients, these are patients that are, you've typically thrown everything at them that you can to get them to ventilate, right? So these are patients that are paralyzed. These are patients that are on, high doses of sedation already just to try and get them to be ventilated. So they're on propofol, they're on ketamine, they're on whatever you can get them on to get them down.
Okay. What was I going to say? So just like how you would have ventilator dependence after a while, I'm sure you have to have close PT, right, with these patients, because I'm sure that if your patient stays on ECMO, they're if you're not exercising them, if the goal isn't to bridge them and just rehabilitation,
Yeah,
right?
specifically with the bridged patients, the LRU over at University of Maryland is excellent at keeping these patients moving. You will see someone walking the halls with an RT
Yes.
with the vent and a perfusionist pushing the pump because they're going to keep them moving.
That blew my mind.
Yeah, it's pretty amazing, and I'm sure, and I know them well just because they lived next door to us when I worked at the CCRU. But I know other units are doing just as well. These patients they're getting them up, they're walking them, PT's working with them, especially the long-term cases.
No, this is it's really a fascinating perspective, because when you think about an ECMO patient, these are patients that are really sick, or else it wouldn't be on ECMO. So we talked a little bit about MI. We talked a little bit about PE as being reasons that people end up on ECMO. Are there any other issues that commonly lead to patients needing ECMO, or at least as common as, ECMO can be? You mentioned LVAD patients, so, severe heart failure. What else are we looking at?
So we're looking at those flu patients that we're getting in that are just sick as snot, like the ones especially those weird strains that are getting the young, healthy, strong men that are just knocking them out, and then they're getting these horrible pneumonias. When winter comes in and flu season comes around, there's been times where hospitals run out of ECMO circuits.
So how about some of these vape-related illness patients? That could be something.
I mean, it could be, yeah. Anything that's causing significant lung injury could definitely be a candidate for ECMO.
I shared a meme the other day that said something like, "Unless you've seen a 20-year-old be terminally taken off of ECMO, don't tell people not to get vaccinated for the flu." And I shared it, even though I've never seen that. But it does blow my mind, just a little bit of a tangent like that, how much the flu can just snow the healthy 24-year-old, otherwise no comorbidities, no health issues, and just so cool. So you said you mentioned the flu, and then the other ailments that we discussed. I do want to transition to I'm sure what folks are thinking about, and I know that I initially, when I saw the picture, I was fascinated by it. But how do we get to the point where we are doing pre-hospital ECMO? How do you, from someone who has been a core part of that team, what aspects do you see integral to the pre-hospital team, and Yeah, let's talk about that first, and then I'll ask my other
Yeah.
question.
So it's a lot of training to be able to get to that point. It's like I said, it's just like putting in a line, but you're putting in a really big line, and you need, especially in the field where you don't have a whole hospital full of resources, you have to be like 100% on your A game, trained like immensely well, and getting people to that level of training, I think, would be one of the hurdles that would have to come over to be able to get to that level here.
And then also, you mentioned how many people. You said minimum was 3, and that was a bad day.
Yeah.
The sheer resources that you would need, even, if we, and I don't mean to sound pessimist when I think that's a common theme that happens when we end up discussing advanced practice stuff on this podcast. I don't mean to seem pessimistic, but I think, and I think Ken's on the same page with me, the amount of education, training, but also the infrastructure you need around you to be able to do these advanced practice things. The Not only would you need like the education, the training, but the equipment, right?
Right.
And the one thing that often I feel like folks forget is you need to practice that skill. If it's a once a year ECMO, then you're not going to be proficient, right? I think similar
Right.
conversations are going on about just endotracheal intubation, right?
Correct. Yeah.
With like credential saturation and stuff like that, we just don't get the volume that you need to be efficient, right? And not efficient, but
Right.
what's the word?
Proficient.
Competent. Yeah,
Yeah.
proficient.
Yeah.
Exactly, in that skill. So, but that being said, like I think models that utilize, like, I mean, obviously they're successful in Europe with the physician-led model, the pre-hospital
Mm-hmm.
physician-led model with a they call them, and I'm not too familiar with what is it, the National Health System or whatever, the
Right.
NHS. They usually have an advanced practice paramedic who, for us, an advanced practice paramedic is someone that goes to UMBC for 2 weeks. Over there, it's like a master's degree that's equivalent to a PA, right? Um,
Right.
so I envision us hopefully at some point getting to a level like that. But I just wanted to paint a bit of a picture of, with this episode, of what is actually happening with these patients, how critical they are, how how should I say? I don't want to use the word risky, but how I don't even know what the correct word is, but I mean, it is how risky of a procedure it is, and how fragile of a procedure it is,
Mm-hmm.
and how many things have to go right to successfully do it. Um,
Right.
I think, and Ken, I would love to hear your thoughts on it. I think first and foremost, like you said, education, training, um, but also the infrastructure to
Yeah.
to be able to make that happen.
Sorry,
It
go
could
ahead.
almost be, so you know how there's like the trauma go team
Yeah.
for shock trauma, where they can fly the physician to the field. I think you would almost want to set it up something like that with an ECMO go team.
Ken, what were you gonna say?
No, I was just going to say, I really unfortunately don't have a lot of hope that we're going to see anything like this in the United States anytime soon. There are some really progressive and aggressive EMS systems out there where you may get physician buy-in and, medical directors responding to the scene and doing something like this. But I mean, as education stands right now in the United States when it comes to EMS, I mean, we can't even agree that paramedics should take biology and anatomy and physiology before they start their class, let alone, doing something, like this. I think a lot of times we think about, it's just a skill, it's just a drug, we can just do it. And for some things that is true, but for other things there really needs to be more training and practice and education, before we do something really radical. And I may be being pessimistic myself, but I've talked to paramedics who don't understand how the electrical system of the heart works, and they're practicing paramedics. So maybe I'm in a pessimistic mood today.
And
But
and honestly though, like, and we're really not trying to be pessimists here. What the goal, and we, Dr. Wittberg mentions it. I feel like every episode that we talk, we try to mention it. The goal of this podcast is to elevate the clinical practice of what our profession does on an everyday basis, right? um, we want to promote the safe practice, but the advanced practice of EMS clinicians, right? Um, and we've been using the term clinician, and that's something that started at my agency recently after the change of executive leadership, and I 110% support that change because even we look at our nurse partners, like you're getting your master's degree in a specialized aspect of nursing, right? And just like that, there's advanced nurse practitioner training, right, and stuff like that. And I think we want when I say we, I mean the paramedic profession wants the respect that you all get as nurses, that PAs get as PAs, that physicians get as physicians, because quite frankly, we do a job where the skills we get to do outside of the hospital, only advanced care providers are doing in the hospital, right? And
Correct.
the role that we're taking, that provider role, where we are approaching a patient, assessing them, making a diagnosis, and treating them, we are functioning as independent providers. So I think that we get a chip on our shoulder to a point, but then we also don't have the education to back it up. I can't agree with Ken enough on the what he said about the electrical system. What's the point of a paramedic being able to ultrasound if they don't know where the spleen is?
yeah,
Quite frankly, like, what's the point? Why are you doing a fast exam if you don't know what you're looking at? And I'll be the first one to say, like, I know where a spleen is, but when I was looking at that ultrasound probe when I did that class, I had no idea what I was looking at. But
and
that,
I
yes,
don't mean to be a pessimist because
yeah.
I would love to see stuff like this come to EMS.
Mhm.
But I think we just have a long way to go.
And
That's what I'm getting.
ultimately, and you can, on our website we have our the 4 mission areas. Um, Ultimately, it comes down to patient care and better patient outcomes. And I fundamentally believe if we advance our education, we advance our practice safely, and in a measured approach with, and this is where Dr. Wittberg would say, with close medical oversight, which is absolutely correct, um, we can do better for our patients, right? Um, and I didn't mean to go on a political tirade about this stuff during an Ecmo episode, but no, this is one of those things where, like, I think it's like the hot thing that EMS clinicians see that on Facebook or on Netflix, and they're like, oh man, I wish we could do this, or like Raboa, right? Like, we're gonna be doing a
Oh.
Raboa talk, like, but like then I see, and I don't know if we were recording when I described the experience I had when I saw a cannulation, and it like blew my mind. Like, for the first time in a while, I was like, "Oh my god! Like, what is going on in here?" And I mean, because the patient's critical, and the intervention that they're doing, but um, that sort of clinical presence, and honestly, I kind of lost my train of thought on that little tirade. But we need that education. We need that that training and that medical know-how, that clinical know-how. And I think that is 100% part of our mission here to get EMS clinicians in the street that kind of knowledge. And that's why we bring experts like you onto our show. And I can't thank you enough for being here, Aaron. This has been great.
Yeah, I'll talk about Ecmo till I'm blue in the face.
Yeah. So, I mean, is there anything else I know we went through a lot of different things. Is there anything from your notes that we missed that you would want on, like, this initial general Ecmo episode? We can definitely do more episodes at a later date on Ecmo as well. I would love to have you on when we record with Dr. Calvano. I think that'll be great as well,
Yeah.
if you're interested.
I would love to. I think what we've done right now is like a really good brief overview on ECMO, kind of like an ECMO 101. Like, this is ECMO, this is what it can do, this is why you would want to do it, and just kind of gives you a good general background, because you hear the word ECMO and it's kind of big and scary. And like, you talked about your first experience seeing an ECMO cannulation, and I can mirror that. Like, the very first time I was involved in a cannulation, it's very big, it's very scary. And even knowing, like, having a knowledge of anatomy and physiology and what ECMO does is still terrifying. So starting with the basics, I think, takes away a little bit of that anxiety about it.
So and that's the last thing that I'll say in regards to, I won't go on another tirade, but I fundamentally believe that when things are going downhill, right, and you're in the back of an ambulance, it's 2 a.m, it's just you and your partner, and your patient is going down the drain. If you have that knowledge, that anatomy and physiology knowledge, right, and you understand the disease process that's going on, at least for me, I feel more comfortable in understanding what's going on and what I can do to fix it. And that's how I personally believe that I have, over time, with experience, become a better clinician. I could not imagine how scary it is when you see someone that's diaphoretic, pale, and with pulmonary edema, but you don't understand how like circulation works, right? And you're just seeing this like magic thing happening that's killing your patient, and you have to do this thing, but you don't know why this thing works, and then you do this thing, this positive pressure, and now your patient's hypotensive, and you don't understand any of that, right? So
and like, oh, I thought I fixed my patient. I checked box A, and they didn't get better.
and this is a personal opinion of mine. I feel that many people that are very, very, very conservative clinicians, maybe they've had a bad experience with the intervention that they did, and they don't know why it went wrong, and no one reviewed it with them, and now they're like, whether it's a conscious or subconscious decision, they don't want to do that again because they don't want to be put in that position again. But that's another conversation. Ken, you got anything?
No, I really don't. I thought that was a fantastic discussion. I really appreciate your time, Aaron.
Yeah, happy to be here.
And it's a great topic that a lot of people don't understand much about. And I found it very enlightening myself.
Thank you so much. So Aaron will definitely be in contact. Thank you so much for joining us. Ken, you want to finish up?
All right. Well, thank you, everybody, for listening to the Alert Medic 1 podcast. Please check out our website. It's www.alertmedic1.com. Check us out on Facebook at AlertMedic1. Check us out at Twitter, alert_medic1. And most importantly, please subscribe to us on the podcast app of your choice. Listen to our episodes, leave us a rating and a review, and let us know if there are topics you want to see us cover. Thank you, everybody. As always, have a safe night.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.